Welcome to our comprehensive guide on pedicle autografts, a set of surgical techniques used in periodontal therapy to cover exposed roots and restore gingival health. In this video, we'll explore the main types of pedicle flap procedures, their indications, advantages, disadvantages, and step-by-step methods. Understanding these techniques is essential for dental professionals aiming to achieve optimal outcomes in treating gingival recession. We'll start by introducing the concept of pedicle autografts and then delve into the specifics of laterally displaced flaps, double papilla flaps, and coronally repositioned flaps. Let's begin our journey into the world of periodontal surgery. Pedicle flaps are surgical procedures where a section of gingival tissue is moved from an adjacent area to cover exposed roots. The tissue remains attached at one end, ensuring a good blood supply and promoting healing. These techniques are particularly useful when there is sufficient donor tissue nearby and are designed to address isolated areas of gingival recession. Pedicle flaps can be customized based on the clinical situation, and their success depends on careful planning and execution. Next, we'll look at the laterally displaced flap, one of the earliest and most widely used pedicle flap techniques. The laterally displaced flap, also known as the sliding flap operation, was first developed by Grupe and Warren in 1956. This innovative procedure marked a significant advancement in periodontal surgery, offering a unique solution for covering isolated, denuded roots. By utilizing tissue from the side of the affected tooth, the technique ensures a robust blood supply and minimizes the need for multiple surgical sites. The laterally displaced flap remains a cornerstone in periodontal therapy, especially when there is adequate donor tissue laterally. Let's explore the advantages of this technique in the next scene. The laterally displaced flap offers several notable advantages. First, it involves only one surgical site, reducing patient discomfort and simplifying postoperative care. Second, the pedicle flap maintains excellent vascularity, which is crucial for healing and tissue survival. Third, this technique is particularly effective for covering isolated, denuded roots, provided there is sufficient donor tissue laterally. These benefits make the laterally displaced flap a preferred choice in specific clinical scenarios. However, like any surgical procedure, it has its limitations, which we'll discuss next. Despite its advantages, the laterally displaced flap is limited by the amount of adjacent keratinized attached gingiva. There is also a risk of recession at the donor site, which can compromise aesthetics and function. Additionally, the procedure may lead to dehiscence or fenestration at the donor site, and it is generally restricted to one or two teeth with gingival recession. These drawbacks highlight the importance of careful patient selection and surgical planning. Next, we'll review the indications for using this technique. The laterally displaced flap is indicated for covering isolated denuded roots, especially when there is sufficient width of interdental papilla in the adjacent teeth. Adequate vestibular depth is also necessary for successful flap movement and adaptation. These criteria ensure that the flap can be positioned without excessive tension and that healing will proceed smoothly. Understanding these indications helps clinicians select the right cases for this procedure. Next, we'll discuss the contraindications to keep in mind. Certain conditions contraindicate the use of the laterally displaced flap. These include the presence of deep interproximal pockets, excessive root prominence, deep or extensive root abrasion or erosion, and significant loss of interproximal bone height. In such cases, the risk of complications increases and alternative surgical approaches may be more appropriate. Proper assessment of these factors is essential before proceeding with the laterally displaced flap technique. The first step in the laterally displaced flap procedure involves making an incision to resect the gingival margin around the exposed roots. This band of marginal gingiva is carefully removed using a scaler or curette. The exposed root surface is then thoroughly planed to ensure a smooth, clean area for flap adaptation. If granulation tissue is present along the incised edge, it should be meticulously removed with curettes. This preparation is crucial for achieving optimal healing and integration of the flap. Next, a vertical incision is made with a No. 15 blade, extending from the marginal gingiva into the mucogingival junction. A clavicular incision connects the vertical incision to the defect. The flap is then raised, utilizing either partial thickness or full thickness reflection. Partial thickness flaps offer rapid healing at the donor site and reduced risk of facial bone loss, but thin gingiva may compromise flap survival. Sometimes, a short oblique incision into the alveolar mucosa at the distal corner of the flap is necessary to allow lateral movement without excess tension. After the flap is transferred onto the adjacent root, it is sutured to the adjacent gingiva and alveolar mucosa using interrupted sutures. Proper suturing ensures stability and promotes optimal healing. The flap should be positioned without tension, and the edges must be closely adapted to the recipient site. This step is critical for achieving successful root coverage and minimizing postoperative complications. Let's move on to the final step of the procedure. Once the flap is secured, the surgical site is covered with a periodontal pack. After 1 week, the pack and sutures can be removed. Post-operative care typically includes analgesics to control pain, while antibiotics are not always necessary unless complications arise. Healing may occur by connective tissue adhesion, connective tissue attachment, or long junctional epithelium. Some studies suggest improved outcomes with citric acid root conditioning. Proper post-operative management is essential for successful healing and patient comfort. To address the limitations of the laterally displaced flap, several modifications have been proposed. One approach involves converging oblique incisions over the recipient's site and a vertical or oblique incision at the distal end of the donor site, making the flap wider at its base. Another modification leaves the marginal periodontium at the donor site undisturbed, reducing the risk of recession and bone resorption. These adjustments enhance the versatility and outcomes of the procedure. The double papilla flap was first described by Weinberg as the double lateral repositioned flap and later refined by Cohen and Ross. This technique is designed for cases where the interproximal papillae adjacent to the mucogingival problem are sufficiently wide and the attached gingiva on an approximating tooth is insufficient for a lateral pedicle flap. The double papilla flap offers a unique solution for specific clinical situations. Let's explore its indications next. The double papilla flap is indicated when the interproximal papillae adjacent to the mucogingival problem are wide enough to provide adequate tissue. It is also suitable when the attached gingiva on an approximating tooth is insufficient for a lateral pedicle flap and when periodontal pockets are not present. These criteria ensure that the flap can be successfully adapted and that healing will proceed without complications. The double papilla flap minimizes the risk of alveolar bone loss, as interdental bone is more resistant than radicular bone. Additionally, the papillae usually supply a greater width of attached gingiva compared to the radicular surface of a tooth. The clinical predictability of this procedure is fairly good, making it a reliable option for selected cases. However, the technique is sensitive and requires precise execution. One major disadvantage of the double papilla flap is its technique sensitivity. The procedure requires joining together small flaps in such a way that they act as a single flap, which can be challenging. Precise surgical skills are necessary to ensure proper adaptation and healing. Despite these challenges, the double papilla flap remains a valuable option in specific clinical scenarios. The coronally repositioned flap, also known as the coronally positioned flap, is a technique used for aesthetic coverage of exposed roots and for reducing tooth sensitivity due to gingival recession. This procedure is particularly useful for treating multiple areas of root exposure and does not require involvement of adjacent teeth. Let's review the indications for this technique. The coronally repositioned flap is indicated for aesthetic coverage of exposed roots and for managing tooth sensitivity caused by gingival recession. It is especially beneficial when multiple areas of root exposure are present, offering a comprehensive solution without involving adjacent teeth. These indications make the technique versatile and widely applicable in periodontal therapy. This technique allows treatment of multiple areas of root exposure with a high degree of success. It does not require involvement of adjacent teeth, making it less invasive. Even if the procedure does not achieve the desired outcome, it does not worsen the existing problem. These advantages contribute to its popularity among clinicians and patients alike. One limitation of the coronally repositioned flap is the need for 2 surgical procedures if the zone of keratinized gingiva is inadequate. This can increase patient discomfort and prolong the treatment timeline. Understanding these disadvantages helps clinicians plan appropriately and set realistic expectations for patients. The first technique for coronally repositioned flap involves making 2 apically divergent vertical releasing incisions from a point coronal to the cemento-enamel junction at the mesial and distal line angles of the tooth, extending apically into the lining mucosa. A split thickness flap is prepared by sharp dissection at the mesial and distal ends, connected with an intraclavicular incision. Facially apical to the recession, a full thickness flap is raised. Once reflected, the root surfaces are debrided thoroughly and citric acid may be used for conditioning. At the base of the inner surface of the flap, approximately 3 mm apical to the dehiscence, a horizontal incision is made through the periosteum, followed by blunt dissection into the lining mucosa to release muscle tension. This allows the mucosal graft to be easily positioned coronally at the level of the cemento-enamel junction. Proper muscle release is essential for tension-free adaptation and successful healing. The flap is secured firmly with interrupted sutures, and additional sling sutures can be placed to maintain the flap in position. A periodontal dressing is applied to protect the wound during initial healing. These steps ensure stability and promote optimal recovery, minimizing the risk of complications. When there is insufficient width of attached gingiva, a 2-stage surgical procedure is recommended. First, a gingival extension operation with a free gingival graft is performed. 2 months later, a secured stage surgery is carried out by coronally repositioning the flap, which may include a free soft tissue graft. This approach addresses the limitations of the single-stage technique and ensures adequate tissue for successful root coverage. The second technique for coronally repositioned flap is the semilunar flap. This method is indicated for areas where gingival recession is only 2 to 3 mm. It offers several advantages, including no vestibular shortening, no aesthetic compromise of interproximal papillae, and no need for sutures. However, it cannot treat large areas of recession and may require a free gingival graft if there is underlying dehiscence or fenestration. The first step in the semilunar flap technique involves placing a semilunar incision that follows the curvature of the gingival recession. The incision should end about 2 to 3 mm short of the tip of the papillae, as the flap derives its blood supply from the adjacent papillary areas. This careful incision design ensures adequate vascularity and promotes healing. Next, a split thickness dissection is performed coronally, connecting the semilunar incision to an intraclavicular incision. This allows the tissue to collapse freely and cover the denuded root. The flap is then held in place with moist gauze for a few minutes, and suturing is generally not required. Periodontal dressing may be applied to protect the site during healing. The tissue collapses freely, covering the denuded root. The flap is held in place with moist gauze for a few minutes, and suturing is not generally required. A periodontal dressing may be placed to protect the surgical site. This simple and minimally invasive approach is ideal for small areas of recession. Pedicle flap techniques, including laterally displaced flap, double papilla flap, and coronally repositioned flap, offer effective solutions for managing gingival recession. Each method has specific indications, advantages, and limitations. Understanding these techniques enables clinicians to select the most appropriate approach for each patient, ensuring optimal outcomes and patient satisfaction. Successful pedicle flap surgery requires careful assessment of the clinical situation, including the width of attached gingiva, vestibular depth, and presence of periodontal pockets. Patient selection and surgical planning are critical for achieving predictable results. Clinicians must also consider the risk of donor site recession and bone loss when choosing the appropriate technique. Healing after pedicle flap surgery may occur by connective tissue adhesion, connective tissue attachment, or long junctional epithelium. The use of citric acid root conditioning has been shown to improve outcomes in some cases. Proper postoperative care, including pain management and wound protection, is essential for successful healing and patient comfort. Educating patients about the benefits and limitations of pedicle flap procedures is crucial for informed consent and setting realistic expectations. Patients should understand the importance of postoperative care, potential risks, and the likelihood of achieving aesthetic and functional improvements. Clear communication enhances patient satisfaction and compliance. Complications associated with pedicle flap procedures include donor site recession, dehiscence, fenestration, and inadequate root coverage. Early detection and management of these issues are essential for minimizing adverse outcomes. Clinicians should monitor healing closely and address any complications promptly. Sutures play a vital role in stabilizing the flap and ensuring proper adaptation to the recipient site. Interrupted and sling sutures are commonly used, depending on the technique. Periodontal dressings protect the wound during initial healing and enhance patient comfort. Proper placement and removal of sutures and dressings are key to successful outcomes. Maintaining good vascularity in the pedicle flap is essential for tissue survival and healing. The flap should be designed and positioned to ensure an adequate blood supply, minimizing the risk of necrosis and promoting rapid recovery. Vascularity is a key factor in the success of all pedicle flap techniques. Pedicle flap procedures are technique sensitive and require precise surgical skills. Accurate incision placement, flap reflection, and adaptation are critical for achieving optimal results. Surgeons must be well trained and experienced to minimize complications and ensure successful outcomes. Choosing the appropriate pedicle flap technique depends on the clinical situation, patient needs, and anatomical factors. Clinicians must evaluate the width of attached gingiva, vestibular depth, and presence of periodontal pockets to determine the best approach. Individualized treatment planning ensures optimal outcomes. Free gingival grafts are often used in conjunction with pedicle flap techniques, especially when there is insufficient width of attached gingiva. These grafts provide additional tissue for root coverage and enhance the success of the procedure. The combination of grafts and flaps offers greater versatility in managing complex cases. Citric acid root conditioning has been shown to improve outcomes in pedicle flap procedures. By conditioning the root surface, clinicians can enhance connective tissue attachment and promote healing. This adjunctive treatment is particularly beneficial in cases with exposed roots and gingival recession. Analgesics are commonly prescribed after pedicle flap surgery to control pain and enhance patient comfort. Antibiotics are not always necessary unless complications arise. Proper pain management and wound care are essential for a smooth recovery and positive patient experience. Long-term outcomes of pedicle flap procedures depend on proper technique, patient compliance, and post-operative care. Regular follow-up and maintenance are essential for preserving the results and preventing recurrence of gingival recession. Clinicians should educate patients about oral hygiene and maintenance protocols. Aesthetic outcomes are important in pedicle flap procedures, especially when treating exposed roots in the anterior region. Proper flap design and adaptation ensure natural appearance and patient satisfaction. Clinicians should consider aesthetic factors when planning and executing these techniques. Advances in surgical techniques and materials continue to improve the outcomes of pedicle flap procedures. Research into new graft materials, growth factors, and minimally invasive approaches is ongoing. Staying updated with the latest developments ensures clinicians can offer the best care to their patients. In summary, pedicle autograft techniques offer effective solutions for managing gingival recession. Understanding the indications, advantages, and limitations of each method is essential for successful outcomes. Proper patient selection, surgical skill, and post-operative care are key to achieving aesthetic and functional improvements. Thank you for joining us in this detailed exploration of pedicle autograft techniques. By mastering these procedures, clinicians can provide patients with effective, aesthetic, and long-lasting solutions for gingival recession. Stay tuned for more educational content on advanced periodontal therapies and surgical techniques.